handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello everyone, so this is Dr. Huyad and today I've been tasked to discuss 4 chapters in Robin's Pathology and I've been given an hour to do so. So definitely hindi ko madadaanan lahat ng diseases at saka lahat ng organs. 200 plus pages yun guys, so baka ma-overwhelm tayo lahat. No? So I'll just be choosing certain diseases as well as organs na I think surely ma-encounter natin sa OPD, sa wards. No? And I'll be discussing the pathogenesis, symptomatology, morphologic findings, in this diseases. So more of depth over breadth tayo guys. Okay? So all images as well as the outline and this data is from Robin's Pathology. No? If I were to choose a single book in med school no, na must read or kung isang book lang talaga pipiliin, it would be Robin's. Na kaya na niya from biochem, micro, definitely lahat ng clinical. So very good book. No? So anyways, no? So mamaya na ulit. Tama na yung mema, mamaya ulit. So, let's start. So, I've been tasked to discuss 4 chapters na head and neck, and then GI tract, liver and gallbladder, and then pancreas. Okay, so more of the digestive tract type. So, we'll start with head and neck. So, Robins usually discuss no, for a specific organ, mga congenital, kung may congenital diseases, inflammatory, infectious, growths, no, like tumors, and then dulo cancer. So ganun na yung magiging outline natin per organ. So let's start first with the larynx. Okay, so inflammation of the larynx, laryngitis. Okay. So there are various causes of laryngitis. The more common ones are the one listed here. No? So una, pwede siya maging part ng ORT. Kasi di ba ang delineation naman ng upper respiratory tract is the vocal cords. No? So everything above the vocal cords, upper respiratory. So larynx, damay ba yan? Pharynx, etc. So pwede siyang part of the upper respiratory tract infection, yung laryngitis. Most common cause, usually viral rin. Di ba? Okay. So another infamous cause of laryngitis is your tobacco smoke no? As an environmental cause. In fact, if you have a heavy smoker no, that will present with throat irritation, na may cough, na may dysphagia, no? It can range from a laryngitis, no? Just like inflammation, to a neoplastic process no? Or cancer. No? So, yun, the range of presentation in a patient na heavy smoker sa larynx pala. Another common cause is your reflux. No? Ito yung usual na dinadiagnose ng mga ENT or mga ORL, di ba? LPR. Para siyang GERD, no? GERD na nasa larynx lang. So, very similar symptomatology, similar trigger, similar rin yung yung management. Pero instead na GERD sa esophagus, sa larynx, LPR, laryngopharyngeal reflux. Another common cause of laryngitis. Okay, so ito very common na may encounter na causes of laryngitis. Now, infection. No? Infection of the larynx can be a part of a systemic infection. For example, TB. No? May disseminated TB ka na part ng larynx. Another quite famous cause is your diphtheria, no? Caused by Corynebacterium diphtheria, which can lead to dahil may inflammation ka, pwede magkaroon ng mucosal edema, no? And then secretions that can lead to respiratory compromise. At yun yung pinaka-problem natin in patients with diphtheria. Although rare na to ngayon no? Because of vaccination supposedly. Okay, itong last two, na specifically involve yung larynx, very common na kino-compare lalo na sa pedia, di ba? Your epiglottitis or kapag dama yung larynx, laryngoepiglottitis, and your laryngotracheobronchitis or mas commonly called CRU. Okay? So very usual yan na distinguish epiglottitis versus croup. Okay? So I'll leave that to Pedia to discuss the details. No? Pero generally, your epiglottitis is more toxic. No? So pag meron kang infant or child presenting with acute symptoms of fever, sore throat, na may dyspnea, and then stridor, no, that tells us it's an upper respiratory tract na involved, ito dalawa agad yung differentials mo. No? Usually kapag epiglottitis, mas toxic looking, mas in distress, mas naka-tripod position. Anyways, your epiglottitis is usually caused by your Haemophilus influenza type B or HIB. No? But because of vaccination, mas common na yung mga non-HIB causes. Pwedeng viral rin. No? Pero mas sikat na cause niya, HIB. Okay? Your croup is more commonly caused by yun, viral talaga. No? And that's your para-influenza viruses. Okay? So, these are also common causes of laryngitis. Okay, so side note lang. Okay, so because very common nga na kino-compare, no? Is this epiglottitis? Is this croup? Usual questions, no? Meron kang case. Ano yung radiographic finding? Okay, so let's try to compare them. So, okay, so ito hindi na to Robinson's, from Nelson's. I just want to differentiate yung radiographic findings from croup and epiglottitis. So pag sinabing croup, laryngo, tracheobronchitis. So let's orient ourselves first anatomy. So posterior, ito yung esophagus, di ba? So ito yung esophagus. Ayan. And then ito, anteriorly, so yung respiratory tract, ito yung larynx, okay? And then your trachea, and then bronchi. No? So kapag meron kang laryngo, tracheo, bronchitis, itong airway na to yung involved. Okay? Itis, inflammation. No? So meron kang inflammation itong area na to, there is edema, and that leads to narrowing of that airway. No? Kapag narrowed yung airway, yung hangin na dumadaan less. No? On radiograph, yung hangin, black. Okay? So yung makikita mo on your radiograph here is that your black part, which is your airway, is very thin, no? Manipis. No? Kaya, siya yung tinatawag na steeple sign. Ano ba yung steeple? Ito yung image sa right. No? Yung sa mga church, yung mga sa roof nila, na maninipis na matataas na parang ito. Yan yung steeple. So, mukha siyang steeple. Yung airway kasi sobrang narrow. Kaya, yung black na yun yung steeple. Okay, compare natin sa epiglottitis. Sa epiglottitis, ito yung epiglottis. Yan. Tapos, sa baba niya, that's your larynx. Okay? So, pag ito namaga, can you imagine? This is the lateral view. No? So, pag epiglottitis, lateral radiograph actually dapat. No? So, ito yung epiglottis mo. Imagine mo, parang ganito. Ito yung epiglottis, and then namaga siya. Kaya siya mukhang thumb. Okay? And being a soft tissue, white yung itsura niya sa radiograph. Okay? So ito yon. So yung ganyan, no? Yan, ganito siya. Mukha siyang thumb. So kaya thumb sign. So croup, dahil narrowing yon, specifically subglottic narrowing, steeple sign. Okay? Pag epiglottitis, namaga yung epiglottis na mukhang thumb sign. Okay, anyway, so ano lang yun. Side note. So basically, these are the causes of laryngitis. Next, no? Okay, so tapos na tayo sa inflammation, let's go with growths. Okay? Very common in the OPD setting. So, meron kang singer or preacher or teacher, ayan, mas common, no? Na biglang after 2 weeks ng daldal, daming lectures, namaos. Okay? Namaos or nagbago yung boses, and then yun, sinilip mo yung throat, ayun, meron kang parang growth here or nodule. So these are your reactive nodules or polyps. Okay? Usually, it's seen in the true vocal cords. Okay? So as you can see, it's smooth, no? Na very rounded lang. No? So meron ka lang growth talaga sa true vocal cords. By convention lang, no? Your nodules are bilateral while your polyps are unilateral. Pero convention lang yan. Basically, pareho lang yan sila ng itsura morphologically. Okay? So aside from singers, teachers, preachers, ano palang common sa kanila? usually meron kang vocal cord strain. Kaya yung growth niya sa vocal cords, yun sa true vocal cords. Okay, so may vocal cord strain ka. Aside from that population, ayun na naman, smokers. No? Pwede ka rin magkaroon ng nodules and polyps in heavy smokers. So anong itsura niya morphologically? Okay, morphologically. So same, no? Meron, it's still a squamous epithelium on the surface. And then inside it are just loose connective tissue. So basically, reactive lang siya na change, okay, to the excessive strain. And then how do you manage? Usually vocal rest. Okay. Now let's contrast that to this, no? Your papilloma. Yeah. So papilloma is more of a benign neoplastic change. Okay. Now grossly, as you can see, it's more of exophytic. No? Meron kang mga finger-like projections rather than the smooth na round lang sa nodule. And it's still soft. Okay? And in adults, usually, solitary lang siya. Very important na clinical application here is that in infants who are born to mothers with genital warts, no, HPV, via vaginal birth, pwedeng maraming mga papilloma makikita sa vocal cords nila. And that's what you call papillomatosis. Okay? Specifically, juvenile laryngeal papillomatosis. So, it's caused by your HPV 6 and 11. No? So, meron kang infant, pinanganak sa mother via na mayroong genital warts via vaginal birth, then magmamanifest ng mga ganitong growth, juvenile laryngeal papillomatosis. Okay, in addition, itong mga papilloma na to, pwede siyang matraumatize that can ulcerate and bleed. So minsan magmamanifest siya with hemoptysis. Okay, now morphologically, as with all papilloma or mga papillary, no, whether sa thyroid yan or sa breast, di ba, ano yung common na microscopic finding? It's your fibrovascular core. So ganun din. No? So meron kang finger-like projections, and then at the core, you have your fibrovascular core. Okay, so now let's go to laryngeal cancer. Okay, so yung laryngeal cancer also manifests a specific sequence. Okay, yung sequence, masikat to sa colon cancer actually, yung adenoma, carcinoma sequence. We'll discuss more of that later. Mas i-discuss natin. Pero sa laryngeal cancer, meron ding sequence. Okay, your hyperplasia, dysplasia, carcinoma sequence. What does this mean? No? So for example, meron kang initiating event such as you would guess, smoking. Meron kang tobacco smoke exposure. That exposure can lead to epithelial changes dun sa larynx. Initially, non-dysplastic, no? Hyperplasia lang. That in fact, if tinanggal mo yung insult na yon, stop siya smoke, yung epithelial changes, mawawala. Okay? Now, this hyperplasia initially has nearly zero malignant potential. Okay? But if you have this exposure to tobacco smoke continuously, chronic, no, for decades, heavy smoking, pwedeng mag-persist yung mga changes. No? And it can progress to dysplastic changes, which already have malignant potential. In fact, the grade of dysplasia correlates also to the risk of malignancy. So for example, kung mild dysplasia lang yan, nasa mga 1 to 2% lang yung risk of malignant transformation. Then pag moderate, mas mataas. Then pag severe, nasa mga 5 to 10% risk of malignant transformation. And then if there is still persistent exposure, na cumulative, that can lead to development of carcinoma. So yun yung sinasabi nitong sequence na to. Another proof, no, that supports the sequence is that if you would check a patient with laryngeal cancer, for example, ito yung cancer. If you look at the adjacent surfaces na hindi naman cancer, there are actually areas of hyperplasia, there are foci of dysplasia, no, na nagsa-start na. Okay? Because same exposure naman, which is your usually and most commonly tobacco smoke. Okay? So yun, meron din siyang sequence. Pero mas i-discuss natin to sa yung sequence sa colon cancer. Masikat yung adenoma carcinoma sequence. Pero just to show that meron din sa laryngeal cancer. Anong classic na presentation ng laryngeal cancer? It's usually a male smoker in the 6th decade of life, chronic, heavy smoker naman. Sobrang daming pack years, no? And then in addition to that, there are also risk factors that are synergistic to smoking. Pinaka-common, alcohol, no? So kung meron kang mga ilang pack years na, tapos heavy alcoholic beverage drinker pa, yun, it contributes to the development of laryngeal cancer. So classic na patient, 58-year-old male, heavy smoker, 30-40 pack years, heavy alcoholic beverage drinker who now presents with hoarseness, okay? Or dysphagia. Now you have yun yung classic na laryngeal cancer. Now morphologically, as with all head and neck, no, usually head and neck cancer, ang morphology is squamous cell carcinoma. So ganun din sa larynx, no? Squamous cell carcinoma in 95% of the time, it's a typical SCC. Now grossly, nagsastart siya with in situ lesions lang, and then magde-develop later into plaques, no? Mga grayish or pearly na plaques, and then ayun na, ito na yung, as you can see in this image, no, fungating masses, no? May areas of ulceration, hemorrhage, necrosis, and then microscopically, the usual na mga anaplastic changes. No? So may mga mitotic figures, may mga giant cells. Okay? So that's laryngeal cancer. So basically that's larynx. Diniscuss natin inflammation, then growths, nodule versus papilloma, and then cancer. Okay, so that's for larynx. Next, another common na may encounter is those that involve the nose and the nasopharynx. So start ulit tayo, inflammation. Okay. So one of the common diseases that affect the nose and nasopharynx, at I'm sure lahat tayo na-experience, is your infectious rhinitis, or more commonly known as the common cold. Okay? So anong most common cause naman ng infectious rhinitis? Viral pa rin. Okay? Specifically, rhinovirus. No? From the name itself, rhinovirus, rhinitis, yung common cause. Other causes, adenovirus, echovirus. Okay? So, yung infectious rhinitis can also be caused by bacterial, usually kapag superimposed on a viral infection. Okay? And since continuation yan, yung upper respiratory tract, pwedeng hindi lang rhinitis, pwede siya mag-spread to sinusitis, okay? Or pharyngitis, and reactive tonsillitis, as we'll discuss later. In fact, di ba, usually kapag may sakit na nagpe-present with nasal congestion or nasal obstruction, na nagkakaroon ng rhinorrhea, di ba? Rhinosinusitis, yun yung usual sakit kasi usually damay-damay ng upper respiratory tract infection. Okay, let's contrast this to your allergic rhinitis or your AR. Usually, mga AR, kasama niya asthma, no? Atopic dermatitis, sa atopic triad, so allergic rhinitis. So, dahil pareho silang inflammation, pareho sila usually ng morphological change. So, meron kang mucosal edema, erythema, meron kang secretion. So, how will you differentiate infectious versus allergic rhinitis? So, your allergic rhinitis is a type 1 hypersensitivity reaction, which is IgE mediated. It has eosinophilic infiltrates. So, yun yung difference. Pero pareho lang sila na meron edema, erythema, and secretions. Okay, next. Kung meron kang isang patient with nasal obstruction, for example, due to deviated nasal septum, or meron kang nasal polyps, as we'll discuss further later, that causes recurrent infection, no? Infectious rhinitis. This can develop into a chronic type of rhinitis or chronic rhinitis. Okay? Kasi nai-impede yung drainage, no, sa nose. At kaya nagkakaroon ng persistent infection and then inflammation and madadamage na siya. So ano yung, in addition to those inflammatory changes, nagkakaroon ka ng mga your desquamation of the mucus and ulceration. Okay, so that's chronic rhinitis. Okay, now sinusitis, as I've said, usually continuation siya, no? Rhinitis, rhinosinusitis. So sinusitis, usually it's preceded by a rhinitis. Okay, so ano yung usual complaints ng patient? Parang barado, merong nasal congestion, tapos merong rhinorrhea or postnasal drip. No? So yun yung usual effect niya. More of discomfort, no? But occasionally it can have more severe consequences. No? For example, dahil meron kang edema dun sa mucosa, pwedeng ma-impede yung drainage which can cause accumulation of pus, empyema, or pwedeng mag-accumulate yung mucus na pinoproduce and can cause mucosin. Okay? Also know that it's very much related to the orbit, no? As well as the cranial vault. So pwedeng yung infection or inflammation doon mag-spread to the orbit or the cranial vault. Pwedeng mag-cause ng osteomyelitis, no? Or pwede ring mag-cause ng septic thrombophlebitis, no? Into the dural venous sinuses. So pwedeng mas malalang effects pag merong rhinosinusitis. Okay, let's discuss this more, no? Nasal polyps. So in a patient na merong recurrent na rhinitis, no, yung area na yon na laging nai-inflame, pwede siyang mag-protrude. Okay? That focal protrusion of an inflamed, no, edematous mucosa, that's a nasal polyp. Okay? So here in the image, ito yung nasal polyp, no, on low power magnification. So ito yung epithelium niya. And then ito, ayun, magang-magang stroma. Meron kang loose, edematous na stroma. And then in high power, you can see it's also very filled with leukocytic infiltrates na halo-halo. Meron kang eosinophilic, meron kang rin neutrophilic infiltrates. Okay? So, yun actually yung nasal polyp. Okay, now, continuing. So sabi ko parang continuum to eh. No? From the nose to the sinuses, pwede siyang mag-spread to the pharynx. No? So pharyngitis, no? To the nasopharynx, pharyngitis. So ang more common cause ng pharyngitis or strep throat or sore throat, is still viral. Kasi sabi ko, rhinitis, sinusitis. Viral actually yung more common cause pa rin of pharyngitis. So kapag may patient or tayo, pag merong sore throat, hindi yan antibiotics agad. Ha? Kasi viral yung most common cause of pharyngitis. And anong virus? Yun pa rin, rhinovirus, adenovirus. So hindi antibiotics agad. Okay, so side note, anong clinical criteria ang ginagamit to distinguish na baka mas bacterial yung pharyngitis na to or baka kailanganin natin ng antibiotics? That's the Centaur criteria. Anyways, so pharyngitis. And then, pwede ka magkaroon ng reactive na changes sa tonsils, no? Or tonsillitis because this is lymphoid tissue. So, pwede ka magkaroon ng reactive tonsillitis. So pwede ka magkaroon ng both. So, pharyngotonsillitis. Again, this is part of a single upper respiratory tract. So, kaya pwede magka-inflammation. Pwede pa rin magkaroon ng bacterial. Same, viral na magkakaroon ka ng superimposed bacterial infection. Anong common na bacterial infection sa pharynx that causes pharyngitis na bacterial? Your group A beta hemolytic strep. Okay? And how do you usually distinguish na mas bacterial to? Part also of the Centaur criteria. Grossly. Mas exudative. No? Meron kang mga exudates or meron kang exudative membranes or pseudomembranes doon. That more likely points to a bacterial type of pharyngitis. But again, most common is still viral. Okay, so briefly, let's just go through the tumors of the nose, sinuses, and pharynx. Relatively infrequent naman itong mga cases na ito. Pero once in a while, no, nakikita pa rin sila sa ER. During my clerkship, nakakita ng mga cases na ito. Okay, so start na tayo sa benign. No? So you have nasopharyngeal angiofibroma. So from the name itself, no, oma, so it's benign, and then angio, so it's a highly vascular tumor. And being a highly vascular tumor, yung main problem natin here is bleeding. No? Pwedeng malalang bleeding, mag-hemorrhage, epistaxis. Okay? So the image to the right is your angiofibroma. So again, from the name, no, angio, so ito yung mga blood vessels with very, very thin wall. Okay? Kaya siya prone to bleeding. And then fibroma. No? So meron kang dense na mga collagenous stroma, no, in between these very thin-walled blood vessels, angiofibroma. Very characteristic rin ng nasopharyngeal angiofibroma. And according to Robbins, no, it's almost exclusively seen in this population, adolescent males. Okay? And ganun rin nga during my clerkship, I saw a case of angiofibroma, adolescent male nga, tapos ang lalang-lalang epistaxis. No? So ganun talaga yung presentation. Sinabi rin si Robbins that they usually occur in fair-skinned and red-headed. Pero hindi naman ganito yung patient nakita ko at least. Okay, another benign tumor is your sinonasal papilloma. No? Also known as Schneiderian papilloma. Schneiderian kasi the mucosa that lines the sinonasal area is also known as the Schneiderian mucosa. Okay? So it's also a benign tumor. And what I want you to remember here is that meron din siyang three types. No? Exophytic, which is the most common. Endophytic is also known as inverted. Inverted kasi yung growth niya papaloob. So yung mga epithelium, ang growth niya papaloob. And then, oncocytic. Although these tumors are benign, sinonasal papilloma, even your nasopharyngeal angiofibroma, even though benign to mga tumors na to, ang problem sa kanila, they are locally aggressive. No? And since they are locally aggressive at yung mga katabi nilang structures, mga orbit, no? Mga cranial vault, doon nagkakaroon ng problem. No? And also your sinonasal papilloma has a tendency to recur. So, now let's go to the malignant one, which is your nasopharyngeal carcinoma. Okay, so merong mga distinct characteristics yung nasopharyngeal carcinoma, especially this three. First, it has a very distinctive geographic distribution. Specifically in Africa, mas common siya sa children. In fact, it's the most common childhood cancer in Africa already, nasopharyngeal carcinoma. Common din siya sa South China, but here, mas common siya sa adults. No? So, may specific locations na nga siya common, may specific populations pa in this location. No? In fact, sa US, hindi siya ganun ka-common. It's a very rare cancer there. No? So, iba-iba talaga. Another thing that is unique with your nasopharyngeal carcinoma is its association with EBV, okay? EBV infection. If you notice, your EBV is also associated with other cancers, no? But usually mga lymphoma na type. So ito yung unique sa EBV. Nasopharyngeal carcinoma is also associated with it. Okay? Very good to remember, also in microbiology. And it's also closely related to your lymphoid tissue. So ang major risk factor is EBV infection. But the other associated risk factors are in your nitrosamines, no, mga fermented food, as well as environmental insults like smoking and chemical fumes. Now, how does nasopharyngeal carcinoma usually present? Actually, initially very clinically silent sila. Usually occult yung presentation until locally advanced na sila. No? In fact, no, pwedeng ang manifestation nila, ito na, cervical lymphadenopathy na metastasis. No? And then dun mo lang malalaman na meron palang nasopharyngeal cancer. But if they manifest, however, with symptoms, the usual symptom is your nasal obstruction. Anong diniscuss natin kanina that can also manifest with a chronic nasal obstruction. Mga nasal polyps rin, no? So you have to really distinguish the two. And then they can also present with epistaxis. Okay? So yun, usual presentation ng nasopharyngeal carcinoma. Now, last na gusto kong matandaan here in nasopharyngeal carcinoma is that it has characteristic patterns. 3 types of patterns. Ang tandaan lang natin dito is your keratinizing and non-keratinizing. So again, squamous cell carcinoma as with most of your head and neck cancers. Okay? So pag keratinizing, usually, or that's also well differentiated. No? Kaya siya nagpo-form siya ng keratinizing. Non-keratinizing is usually undifferentiated. Anong implication nun? Yung non-keratinizing or your undifferentiated, siya yung mas radiosensitive. No? Being undifferentiated, mas mas nagre-respond siya to radiotherapy and hence has a better prognosis. No? Important to remember that. Okay, so that's it muna for our head and neck. No? So these are the more common diseases that you likely encounter in our rotations. So now let's move on to the GI tract. So ito mas maraming diseases dito at saka mas mahaba itong chapter na to. So hindi natin magagawa yung nadaanan natin yung mga diseases from inflammation to cancer per organ. So we'll just be choosing high yield concepts in pathology that relates to diseases of the GI tract. So let's start first with congenital abnormalities that may affect the entire GI tract. Okay, so we have agenesis, atresia, fistula, and stenosis. No? These more commonly affect what part of the GI tract? No? Although it can affect the entire part of the GI tract, usually, as we usually encounter this in sa esophagus. Okay, so let's define first. When you say agenesis, that means wala talagang development. Hindi talaga nag-develop. Absent yung organ na yun. And that's quite or extremely rare even sa esophagus. Mas common is what we call atresia. When you say atresia, it developed incompletely such that wala kang kanal. Atretic talaga. Okay? And you're left with just a cord. Okay? And the most common location of esophageal atresia would be close to the tracheal bifurcation. Diba? Your esophagus is posterior to your trachea. Nung nag-bifurcate yung trachea, posterior doon usually nagkakaroon ng atresia yung esophagus. And how will that manifest? No? So, kung kakain yung baby, wala siyang daluyan, walang kanal. So usually there is regurgitation after feeding. Okay. So, again, more common yung atresia sa esophagus, pero pwede rin siya sa mga intestine. So let's focus sa esophagus first. Often, kung merong atresia, may associated rin na fistula. Okay? And the esophageal fistula is usually connected to the sa harap niya, trachea or minsan bronchi. No? So that's what you call tracheoesophageal fistula. So ano yung manifestation naman ng fistula? So yung food, hindi na nga siya pupunta sa GI tract, dediretso pa siyang respiratory tract. No? And pag napunta siya sa respiratory tract, pwede ka magkaroon ng aspiration, or suffocation, and pneumonia. And dahil hindi siya nakarating sa GI tract, pwede ka magkaroon ng fluid and electrolyte imbalances. Now, briefly, let's discuss the types of your esophageal atresia and tracheoesophageal fistula. Madali lang naman to. No? So, A, B, C, D, E. Okay? A, atresia lang. Atresia lang. Wala kang fistula. B, your fistula is the proximal segment. C, the fistula is the distal segment. D, dalawang fistula yung meron ka. E, your esophagus is intact. No? And you just have a fistula. So walang atresia, fistula lang. Okay. So among this A, B, C, D, E, the most common is ito, C. C is the most common. Okay. Anyways, and then you have stenosis. No? When you say stenosis, nag-develop siya pero narrowed yung lumen. So merong kanal pa rin pero narrowed lang. At bakit siya narrowed? Dahil yung wall surrounding kumapal. No? So meron pa ring passage pero very much limited. Okay? So as I said, esophagus yung usual. No? But pwede rin sa intestine such as the duodenum. The most common na location of an intestinal atresia is, would you like to guess? It's the imperforate anus. No? Imperforate anus is the most common form of intestinal atresia. Okay, so that's for atresia. Next, let's talk about mga butas. So lahat ng mga to, next set, puro yan butas no? In the abdominal wall or abdominal cavity. When you say diaphragmatic hernia, yung butas nasa diaphragm because the diaphragm incompletely develops. No? So nag-close yung diaphragm, may mga portion na hindi na-close at yun yung butas na yun. So what happens, there's communication now between your abdominal cavity and your thoracic cavity. Specifically, what happens is that abdominal viscera will herniate to the thoracic cavity. Anong mangyayari nun? No? during development, sisikip yung lugar for the lungs, no? And it will impede lung development and can lead to pulmonary hypoplasia. If malaki yung butas, maraming abdominal contents na pumunta sa thorax, pwedeng sobrang lala ng pulmonary hypoplasia that it can be incompatible with life. Okay? Now, the next two, pareho itong mga butas sa abdominal wall. Okay? At ito rin yung usually kini-compare contrast. No? When you say yung phalloceal, yung butas only involves the muscle layer. Okay? Muscle layer lang ng abdominal wall. Pag gastroschisis, lahat ng layers, no? Yung buong abdominal wall from the peritoneum to the skin, wala. No? And so, kapag omphalocele, meron ka pa rin sac. No? So, dahil may kulang lang na muscle na layer, magpro-protrude siya, no? to the outside na dahil weak yung wall. Pero meron kang sac, may covering pa rin yung mga viscera na yun. In contrast, yung gastroschisis, wala talagang kahit ano dun. So, labas na labas yung abdominal viscera. And there is communication between the environment and the surface of the viscera. Okay? Walang sac, yun yung kaibahan ng gastroschisis. So ano mas malala? On its own, mas malala yung gastroschisis, no? Because there's direct communication. Walang any cover talaga doon sa nag-protrude na part from the abdomen to the environment. But your omphalocele tends to be associated, no, 40% of the time with other birth defects. No? So kung may omphalocele ka, baka meron pang ibang mga congenital defects because it's a midline defect. No? So meron ka rin mga ibang midline defects along with your omphalocele. Okay. Next. Now, another common congenital disease is your Meckel diverticulum. So, what is a diverticulum? Pag diverticulum, it is an outpouching of the wall. So, kung ito yung wall ng GI tract, meron kang part na nag-outpouch. It can be true or false. No? Pag true, lahat ng layers ng wall na yun nag-outpouch. Pag false, only a part. May layer lang na medyo mahina kaya siya nag-outpouch. Ganun usually sa diverticulosis, for example, no? In elderly people na weak na yung wall dahil through age, diet, nagkakaroon ka ng outpouching pero false yun kasi yung weak part lang, yun yung nag-outpouch. Sa Meckel diverticulum, which is a true diverticulum, lahat yun ng layers ng wall ay meron sa outpouching. And the most common na true diverticulum is congenital and is Meckel diverticulum. Ano yung nangyari? Ano yung cause? It's because during development, your vitelline duct, no? Di ba? Your vitelline duct is a connection between your yolk sac and your midgut, no? The small intestine. So yung connection na yon, which is necessary in fetal development, dapat pag pinanganak, wala na, mag-involute na yan. Dapat mag-regress na yon. Pero in this case, hindi siya nag-involute. And hence, meron ka pa rin parang outpouching doon sa small intestines. Now, the most common location is the ileum, and usually in the anti-mesenteric side. No? So look at the image in the right. So this is your small bowel. Ito yung mesenteric side. Ito yung anti-mesenteric side. And this is your Meckel diverticulum, which is a complete, full outpouching ng entire wall. Hence, a true diverticulum. Now, yung sikat dito sa Meckel diverticulum is your rule of twos. No? So, 2% of the population is affected. It's usually within 2 feet of the ileocecal valve, proximal or distal? Proximal, no? Kasi most common, ileum. Within 2 feet, it's usually 2 inches long. No? So ito yung pwedeng malito, no? 2 feet, 2 inches. So hindi naman siya ganun kahaba. Mga 2 inches lang. Within 2 feet yung location niya. Okay? It is 2 times more common in males, no? And only a few are symptomatic. No? Mga 4% lang yung symptomatic. But if they are symptomatic, they usually manifest at age 2 rin. Okay? So yun yung rule of twos. So ano yung usual symptom na pinapresent nila? Now, ang symptoms ng Meckel diverticulum is an effect of the ectopit gastric tissue or pancreatic tissue. Ibig sabihin, may gastric tissue ka sa intestines. No? And because they are gastric tissue, they tend to secrete gastric acid. No? And that acid can cause ulceration, bleeding, and abdominal pain resembling acute appendicitis. Okay, last na common rin na congenital disease is your Hirschsprung disease, which is also known as congenital aganglionic megacolon. So from the name pa lang, congenital, so the cause of it is usually during the developmental process. So initially, you have your neural crest cells that migrate normally from the cecum papuntang rectum. Ang nangyayari, bago pa sila nakarating sa rectum, namatay na sila. No? Or pagdating nila agad, patay agad. No? So there's premature arrest in the migration. That is why the rectum is almost always involved in Hirschsprung. No? Ang tanong na lang, how much of the colon is involved? Kasi mas malayo ang rectum, mas malayo yung journey ng neural crest cell. So definitely, kung may Hirschsprung, yung dulo yung pinaka-affected. Tapos iba-iba yung variable yung effect sa colon. Minsan, sigmoid colon affected, minsan yung buong colon affected. No? So yun, basta ang rectum, always affected. So dahil hindi nakarating ang neural crest cells, anong mangyayari? Wala kang enteric nervous system here. So you have lack of your Meissner and our back plexus. That is why it's called a ganglionosis. No? Wala kang ganglion cells here. And as a result, you have a functional type of obstruction. Okay naman, grossly, pero hindi siya, walang peristalsis. So, sa stuck yung food, no? Yung poops na stuck sa dyan. Now, what is good to know here is that the one that is affected, no, yung segment na affected, which is the more distant, grossly mukha siyang normal. Okay? Kasi functional nga yung main problem. Okay? But the proximal segment, dahil stuck sa kanya yung poops, hindi makalabas doon, dilate siya ng dilate. And that can be massively distended, hence, megacolon. Megacolon. Now what happens is later on, dahil dilate siya ng dilate, ninipis yung wall, intestinal wall, pwedeng mag-rupture, nag-perforate, then mag-peritonitis. No? So yun yung mga complications from it. Hence, in order to diagnose Hirschsprung, you have to prove na merong aganglionosis. May area of aganglionosis. Usually, sinistain nila yan no? With acetylcholinesterase. Kung wala, ibig sabihin walang ganglion cells. No? Okay? And then, grossly, as you can see in this image, no? Ito yung very much distended na megacolon. Proximal yan to the affected segment. The affected segment is not the one that is dilated. It's the proximal part of the affected segment. So, if you look at this, normal actually na meron siyang mga ganglion cells. Okay? Now, how do Hirschsprung disease usually present? No? It's usually pagkapanganak. Immediate postnatal period, hindi siya nag-poops. No? Wala, failure to pass meconium. And then later on, dahil nasa stuck yung poops, pwedeng mag-abdominal distension, then mag-vomiting. Okay. So, okay, that's it muna for congenital anomalies involving the entire GI tract. So now let's go per organ, starting with the esophagus. Okay. So sa esophagus, normally, it's lined with stratified squamous epithelium. Ang purpose nun para to protect it from abrasion kapag dumalo yung food, which is the purpose of the esophagus. Pero hindi siya handa if meron kang mga acid, gastric acid na bumalik doon. Okay? So, hindi siya ganun ka-resistant kasi hindi yun dapat talaga pupunta doon. So, in order to maintain that na walang acid na bumalik, important lower esophageal sphincter. So may sphincter action ka, the lower esophagus, to make sure na hindi makabalik yung gastric acid to the esophagus. At the same time, kailangan niya rin mag-relax paminsan para mag-pass through yung food. So kapag OA yung pag-contract or masyado siyang relax, then you have these diseases. No? So pag OA yung pag-contract ng lower esophageal sphincter, that is achalasia. So that is because of incomplete relaxation of your lower esophageal sphincter. And hence you have this triad. Incomplete lower esophageal relaxation that leads to an increased lower esophageal tone. And ultimately, your esophagus also is a peristaltic. Okay? Now, achalasia can be a primary or secondary to another disease. Primary achalasia usually involves degeneration of the ganglion cells at the lower or distal esophagus. No? May ganglion cells ka dyan that normally are inhibitory to the tone. No? So, pag wala yung mga inhibitory na yon, di maintained na may tone siya. No? Hindi siya nagre-relax and hence leading to achalasia. Now, secondary naman is you have a disease that destroys those ganglion cells. Pinaka-example and the most common cause of secondary achalasia is Chagas disease. Chagas disease is caused by Trypanosoma cruzi or American Trypanosoma. Aside from achalasia, may kinokos pa yung Chagas disease na medyo na-discuss natin kanina o bago lang. Megacolon. So a ganglionic megacolon na hindi congenital, Chagas disease can also be due to Chagas disease. Now, other diseases that affect the neurons there, like diabetic neuropathy, polio, similar effect. Or infiltrative diseases like cancer or amyloidosis or fibrosis. Okay? So, how does this manifest? Since masyadong contracted, hindi makadaan madali yung food, mayroon kang dysphagia, as well as difficulty in belching and chest pain. Clinical lang. Radiographically, how will you see achalasia in the next year? Ano yung classic description? Bird's beak. Kasi yung portion na lower esophageal sphincter masyadong contracted. Okay, yung opposite niya is if masyado namang relaxed yung sphincter. Masyadong relaxed or nagre-relax siya kaya hindi niya kailangan, kaya bumabalik yung gastric acid to the esophagus and leads to reflux esophagitis or clinically mas alam natin as GERD. Okay? So again, the most common cause is transient lower esophageal relaxation, which can be due to gastric distension, stress, no? Pwede rin alcohol and tobacco smoke, yung mga alam nating triggers for GERD. No? Or, no? Pwede rin isang cause ng reflux esophagitis is if mataas yung intra-abdominal pressure, such as in pregnancy. No? Yung mga pregnant women tends to have more common na GERD. Okay? So clinically, how does that manifest? Mga heartburn, mga regurgitation, kung malala, pwedeng parang chest pain. Now morphologically, most, lalo na yung mga transient lang, simply hyperemia lang itsura. If tingnan mo sa endoscope, parang yung sa esophagus, like in the one on the right, here, parang may red areas ka lang, hyperemia. Ito, merong mga mas varied yan, as we'll discuss later. Pero yun, simple hyperemia na. But if ulit-ulit na nag-esophagitis, chronic and severe, pwede ka ng mga may eosinophilic infiltrates and then later on, even more severe neutrophilic infiltrates. So kapag ang esophagitis mo, may neutrophils na, malala na yun. Other findings include basal zone hyperplasia as well as lamina propria. So mga reactive changes. So generally parang inflammatory and reactive changes lang. Now, the next diseases are progression for this. No? Kung paulit-ulit kang nag-GERD, no? That can lead to what we call Barrett esophagus. No? Now, initially, kapag nag-GERD ka, inflammation lang. No? But in time, there can be already metaplastic changes. Okay? Intestinal metaplasia, which is a hallmark of your Barrett esophagus. Dapat, di ba, walang columnar mucosa sa esophagus, sabi ko kanina, stratified squamous. So kapag may columnar ka, abnormal. Ano ang clinical significance kapag nakadetect ka ng Barrett esophagus? It is the increased risk of being a precursor lesion to esophageal adenocarcinoma. Take note, adenocarcinoma. Okay? So, very important. Now, paano usually yung detect? No? For example, isang patient, laging nag-GERD. No? So, when you do an endoscopy, ito yung makikita mo. So, grossly, you will see patches or red velvety mucosa. So, itong image here, this one on the left, ito yung normal esophagus. Nakita mo yung junction, ito yung esophagus, ito yung sa stomach part. No? Here, meron kang patches or tongues, no, of red velvety mucosa going up, no, lampas na ng gastroesophageal junction. And if you do a biopsy of that, makikita ka ng itong dalawa, which are requirements to diagnose Barrett esophagus. So una, sabi ko kanina, hallmark, intestinal metaplasia. Meron kang columnar mucosa above the gastroesophageal junction. So pag may nakita kang columnar mucosa above the gastroesophageal junction, mali yun, abnormal yun. Kasi dapat walang ganun. Okay? And you also need to see your goblet cells. Ito, mga goblet cells. So these two will be diagnostic already of Barrett esophagus. Now, in addition to that, pag meron ka ng Barrett esophagus, tas meron ka pang dysplastic changes. Okay? So ano yung mga dysplastic changes? No? The usual, mga atypical mitosis, mga nuclear hyperchromasia, no? They further increase the risk of developing adenocarcinoma, being a pre-invasive change. No? And meron din yung levels. No? Pag mild or high level of dysplasia, okay? So anong implications rin no? Clinically? Kapag meron kang nakitang Barrett na may high dysplasia pa, mas magiging aggressive ka sa management kasi alam mong papuntang cancer na talaga yun. In contrast, kapag mga Barrett esophagus lang, walang dysplasia or mild dysplasia, pwedeng more of surveillance yung management. So yun yung importance. No? So ito, yung mga nakasulat here, these are just clinical clues, no? That will tell you na baka mas likely may dysplastic changes na itong Barrett esophagus niya. Again, prolonged symptoms. Matagal na siyang nag-GERD. Mahaba yung involved na Barrett at ang mahaba sa kanya ay more than 3 cm. And then older and in Caucasian na face. Okay? So, ganun. So, meron kang GERD. Ang unang finding mo, morphologically, reflux esophagitis. Paulit-ulit ka, pwedeng mag-develop ng Barrett esophagus. And if that tail continues, that can already progress sa pinatatutan natin esophageal cancer. Okay. So, important lang ma-differentiate dito sa esophageal cancer is between adenocarcinoma and squamous cell carcinoma. So, yun lang yung kailangan natin malaman or goal natin dito. Ano yung characteristics ng dalawa? So, tatlo yung main differences niya. Una, your adenocarcinoma, as we've said, siya yung may precursor na Barrett esophagus. Okay? And hence, since Barrett esophagus yung usual na precursor niya, ang pinaka-important na risk factor niya ay GERD. No? Paulit, chronic na GERD. Okay? So, most adenocarcinoma come from Barrett esophagus, pero hindi lahat ng Barrett esophagus, or only a few percent, actually progress to adenocarcinoma. Okay. And then third is that its location. Usually, it's found in the distal third of the esophagus. Okay? So adenocarcinoma, siya yung galing sa Barrett, isang patient na laging nag-GERD, at if you look at it grossly, distal third of the esophagus yung involved or yung tumor. Let's distinguish that from squamous cell. No? Squamous cell, ang usual precursor niya is a squamous dysplasia. Okay? And ang mga risk factors na ay itong mga nakasulat. Anong common sa kanilang lahat? Basically, they damage your esophagus. No? Alcohol, tobacco, caustic injury, ito laging umiinom ng maiinit na beverages, radiation. No? By the way, alcohol and tobacco use are the more common na synergistic risk factors for developing esophageal tumors. O parang familiar, may ganun din cancer na itong dalawa na synergistic na na-discuss natin kanina. Laryngeal cancer. And then, as we compare, yung usual location niya is in the middle third esophagus. No? So, ito grossly, ito yung images ng adeno versus squamous carcinoma. So, adenocarcinoma, ito yung nasa may distal third siya. In fact, it can even involve part of the gastric cardia. No? Sa squamous cell, ito nasa middle of the esophagus and meron kang strictures involved. Which is the most common among the two? Most common na type of esophageal cancer. Worldwide, it is still squamous cell carcinoma. Okay? Squamous cell carcinoma is the most common esophageal cancer worldwide. Okay? Isipin nyo na lang parang esophagus, medyo nasa head and neck pa rin yung part niya. Kaya, di ba, head and neck usually squamous cell carcinoma. However, in the Western world, sa US, mas nag-i-increase na yung incidence ng adenocarcinoma. Okay? Symptoms-wise, no? Since meron kang tumor, meron kang growth or stricture sa esophagus, ang manifestation, dysphagia. No? Usually progressive dysphagia. One keyword, progressive. Una, solid lang. Then may dysphagia na rin siya sa liquid. Then may odynophagia. And then you can have constitutional symptoms such as weight loss. And esophageal cancer usually advanced na rin once you have symptoms. And you have lymphatic spread. Very common yung lymphatic spread. At characteristic rin ng lymphatics ng esophagus ay iba-iba siya per location. Upper, middle, lower, third. Sa surgery, mas i-discuss siguro yun. Pero sige, intro lang. Pag upper third, usually nasa mga cervical. Middle third, mga tracheo, bronchial or mediastinal. And then lower third, ayun, sa gastric na, gastric cilia. Okay? Anyways, that's how esophageal cancer usually present already. Okay, so that's it for the esophagus. Now let's go to the stomach. Okay, chronic gastritis. So the most common cause of chronic gastritis is H. pylori, H. pylori infection. And the second most common, pag walang H. pylori infection, it's usually an autoimmune gastritis. So H. pylori is usually transmitted primarily by fecal oral. And it manifests with gastritis predominantly affecting the antrum. And there is normal to increase acid production. In contrast, yung autoimmune gastritis, it is autoimmune because you have your CD4 T cells that attack your parietal cells. Okay? And your parietal cells are the one that produce HCl as well as intrinsic factors. So definitely bababa yung acid production here. And it hence manifests with atrophic type of gastritis. Okay? Your H. pylori can also later on, pag chronic na prolonged na infection, pwede ring maging atrophic siya later on. Okay? But to differentiate, yung H. pylori, yung atrophic gastritis niya na later on, multifocal. In contrast to your autoimmune, which is diffuse. Okay? So most common cause of gastritis, H. pylori. Pero most common cause of atrophic gastritis will be autoimmune gastritis. Okay, now let's compare the two. So as I've said, ang H. pylori predominantly nasa antrum. Okay? Yung autoimmune, in fact, spares the antrum. And since ang target niya ay parietal cells, which are found in the body, yun yung predominant na na-affect sa kanya. But again, it's usually diffuse. Okay? Now, I've also mentioned na the H. pylori can have normal to increased acid production. No? And if you recall your physiology, ano ba ang trigger ng gastrin secretion by your G cells? Acid. No? So kapag mababa yung acid, tataas yung gastrin secretion to increase acid production. So kung normal to increase yung acid production, edi normal lang yung gastrin secretion sa H. pylori. No? In contrast, your autoimmune, as we said, ang target niya ay yung mismong parietal cells that produce the acid. So definitely decrease the acid production dyan. At in fact, achlorrhea pa. Malalang decrease acid production. And as a result, dahil mababa yung acid, matitrigger yung gastrin secretion. It can be increased to markedly increase gastrin secretion. As we mentioned also earlier, H. pylori later on pwede maging atrophic. So pwede pa rin maging slightly decrease yung acid production or hypochlorrhea yung H. pylori later on. Pero hindi pa rin achlorrhea katulad ng autoimmune gastritis. Okay, now ano yung consequences nila? Yung H. pylori, dahil nagkakos siya ng increased acid production, pwedeng ma-affect yung sunod niya, which is the duodenum, and can lead to duodenal peptic ulcer. Okay? In contrast, your autoimmune gastritis, dahil target niya parietal cells, aside sa HCl, ano pa bang pinoproduce ng parietal cells? Intrinsic factor, no? Which is important for vitamin B12 absorption. So meron kang vitamin B12 deficiency, no? Which can manifest with pernicious anemia or mga peripheral neuropathy or mga degeneration of your posterior columns. So B12 deficiency, yun yung usual na sequelae ng autoimmune gastritis. Both of this, especially kapag atrophic na yung gastritis, can lead to adenocarcinoma. Okay? So pareho silang pwedeng mag-lead to adenocarcinoma. Ang difference is your H. pylori, in addition to gastric adenocarcinoma, because it causes lymphoid proliferation, can trigger formation of your maltoma. Okay? In contrast, your autoimmune gastritis, dahil sabi natin kanina, increased yung gastrin secretion. Ano pa bang ginagawa ng gastrin aside from increasing acid production based on physiology? It causes endocrine cell hyperplasia. And that can lead to development of neuroendocrine tumors or carcinoid tumors. Okay? So, yun. So it's easier to remember the table, no, if we understand ano yung nangyayari. Now, since H. pylori, as I've said, is via fecal-oral route, no? Ang usual risk factors nito or background ay mga nasa low socioeconomic status, no? Living in poverty or rural areas. In contrast, your autoimmune, no? As with all autoimmune disease, pag meron ka isang autoimmune disease, baka meron pang iba. No? Sama-sama din sila. So, possibly meron rin siyang mga thyroiditis, mga Hashimoto, mga type 1 DM, or mga Graves' disease. Okay? So, important to distinguish these two types of chronic gastritis. Okay. Now, I mentioned that the sequelae of both these gastritis can be adenocarcinoma. So, let's discuss that. No? Gastric cancer, majority, most common, 90% of the time is adenocarcinoma. So yun lang muna i-discuss natin now. Okay. So it is associated, as we mentioned, with atrophic gastritis. So H. pylori, autoimmune, yun yung mga risk factors. And in addition, as we mentioned in esophagus earlier, pwede kasing kung meron kang esophageal cancer, may Barrett esophagus ka, pwedeng madamay yung gastric cardia. Pwede ka rin magka-adenocarcinoma dun. No? So that's also a risk factor, yung mga may Barrett. Okay, so ang important natin malaman here ay yung two types and distinguishing these two types, which is your intestinal type versus diffuse type. Kasi medyo iba sila. We'll distinguish them in three parameters: pathogenesis, gross features, and microscopic features. Pathogenesis. No? So yung pathogenesis ng intestinal type is that para siyang loss of function of APC and gain of function of beta-catenin. Familiar? If you recall your chapter 7, ganun din sa mga intestinal colon cancer. Okay, so may natin i-discuss yan. Pero very similar pathogenesis. No? In contrast, your diffuse type is a loss of your E-cadherin. Na-mention ito sa chapter 7. So ano ba yung E-cadherin? It's important for cell adhesion. And if you have loss of that, nagkakaroon ka ng discohesive cells, which is characteristic of cancer. Oh, ano pang isang cancer na may loss of E-cadherin din? Mga lobular breast cancer. So if you have a loss of E-cadherin, pwedeng may associated gastric adenocarcinoma na diffuse type, meron kayong lobular breast cancer. So kung meron kang BRCA2 mutation, part yun ng possible cancers. Okay, grossly, ang intestinal type, meron talagang mass. No? May tumor ka. It's an exophytic mass na pwedeng ulcerated. Okay, the image here na nasa taas, ito yung intestinal type. Ayan, meron ka talagang bukol na meron ulceration. And if you distinguish this ulcer, paano masasabi kung ito ay ulcer ng cancer or mass ulcer na peptic ulcer? So pag cancer, yung edges na heap up edges, no? Taas, no? Heap up edges. In contrast, your peptic ulcer, punched out defect. So malinis, no? Punched out defect. Okay, sa diffuse type, ang gross feature niya, wala masyadong mass. Wala kang makikitang visible mass. No? Instead, what you see is because of a desmoplastic reaction, yung mga normal na rugal folds ng stomach, hindi na nakikita. Okay? It stiffens the gastric wall and then it flattens the rugal fold. And that is characteristically called your linitis plastica, which means leather bottle. Para siyang leather bottle appearance. Okay? And then lastly, microscopically, dahil intestinal siya, no, mas glandular yung itsura ng cells, no? And then with abundant mucin. Okay? I'll show that in the next slide. In contrast, yung diffuse, as I've mentioned, dahil by loss of ink-adhering ka, discohesive yung cells. No? And in addition to that, you have this characteristic signet ring morphology. Okay? That signet ring is due to malaki yung mucin vacuoles. No? So, sige, pakita ko na lang itsura. So, ito sa taas, this is your intestinal type. Itong sa baba, ito yung diffuse. No? Look at this. Because of the large mucin vacuole, it pushes your nucleus to the periphery. Okay? It pushes your nucleus to the periphery. Kaya mukha siyang signet ring. Parang ganito. May ganyan. Signet ring appearance. Okay. So yun, important to distinguish these two types. Okay? Very, very different talaga yung itsura nila. As well as pathogenesis. Okay. Now, the most important prognostic factor in gastric cancer is the depth of invasion. Diba usually, pag size, no? So pag gastric cancer, it's depth. And your METs, both nodal and distant METs, take note at the time of diagnosis. Okay, so this is the most important prognostication for gastric cancer. So sige, para pampagising, try natin na yung mga eponyms nitong mga METs na to. Okay? Nodal and distant METs. So kung meron kang METs sa supraclavicular lymph node, anong tawag dyan? That's your Virchow node. Okay? Pero yung umbilical, anong eponym? Pero yung umbilical, 3 names, no? Sister Mary Joseph. And then left axillary, ito hindi masyado sikat, Irish node, okay? A METs in the ovary, that's your Krukenberg tumor. And then pouch of Douglas, that's your Blommer shaft. Okay, so mga eponyms lang ng nodal and distant METs. Okay, so that's for the stomach. So last na, let's go to the intestines. Okay, kapit lang, malapit na tayo sa puwet. Okay, so let's start with intestinal obstruction. 4 major causes of intestinal obstruction are the following diseases, which account for more than 80% of intestinal obstruction. Okay? So first, the most common cause of intestinal obstruction worldwide is actually herniation. When you say herniation, that's any weakness or defect that causes protrusion of the viscera. So it can occur anywhere, no? Pwede sa groin, pwede sa umbilical area, pero pinaka-common sa groin, specifically inguinal hernia. At siya rin yung common na nag-cause ng intestinal obstruction. So paano nagkakaroon ng intestinal obstruction sa hernia? So what happens is, itong neck na to ng hernia is very much narrow. Narrow yung butas, pero yung sac is quite large. And as venous drainage is impeded, nag-accumulate yung blood dito, kaya mas lalong lumalaki yung sac. Mas lalong nako-compress yung bowel na nasa loob ng sac. And that causes obstruction. External herniation, and then obstruct siya. Aside from that, pwede rin ma-impede yung blood flow, can cause strangulation, ischemia, and infarction. Okay. Next, the most common cause of intestinal obstruction in the US naman, specific, ay adhesions. Okay? So adhesions are when you have fibrous bands or adhesions between bowels. So paano nagkakaroon ng intestinal obstruction dyan? So what happens is, itong area na to ng bowel, ay nagkaroon katuloy ng closed na loop. Okay? That closed loop, pwedeng pumasok dyan yung ibang bowel. At pag pumasok sila dyan, pwede silang maipit. Basically, para silang hernia. No? That's why it's also known as internal herniation. Okay? So same with an hernia. No? Narrow na to, pwedeng makonstrict yung intestine can also impede your blood flow. Pwede ka rin magkaroon ng strangulation, no? And ischemia and infarct. Very similar to radiation. Anong causes ng adhesions? No? Pinaka-famous, surgery. No? Or other inflammation, pwede peritonitis, endometritis. So, possible ba na magkaroon ka ng adhesion kahit walang surgery? Pwede, no? So, in a patient with obstruction or manifesting with intestinal obstruction, na walang history of surgery, possible pa rin na may adhesions. No? If may history siya ng mga peritonitis, etc. Next, no, is the volvulus. Volvulus is defined as the twisting of the bowel loops along its mesenteric side. Okay? So, usually nangyayari to kapag mahaba yung bowel, no? Or redundant. Saan yun usually? Sa sigmoid colon. Okay? And similarly, magkakaroon ka ng obstruction, pati yung vessels pwede rin ma-compress, kaya pwede ka rin magkaroon ng ischemia. And then lastly, the most common cause of intestinal obstruction in children younger than 2 years old is intussusception. Okay? So what happens here? Your proximal segment telescopes into the lumen of the distal segment. Okay? And pag nag-peristalsis to, mas lalo siyang papasok. No? At the same time, i-constrict niya itong area na ito ng lumen. Kaya magkakaroon ka ng obstruction. In most cases, in these children, idiopathic. No? But sometimes it's associated with what? Rotavirus vaccination. No? Kaya usually may mga limits, no? Until this age lang mag-rotavirus vaccination because the risk-benefit ratio favors now the risk of intussusception. Kaya hindi na siya ganun ka-recommended. Also in viral infection. No? Anong common sa kanila? Yung rotavirus and viral infection. Ang nangyayari dyan, your Peyer's patches ay kumakapal. No? And that acts as a leading edge para ipasok yung intestine into this. No? So, mas common intussusception. Sa adolescent and adults, pwede ba magkaroon ng intussusception? Pwede pa rin, no? And very, very rare yon. At if merong intussusception in that age group, isip ka ng something inside, no, intraluminal that acts like a leading edge, parang yung Peyer's patches, usually ng intraluminal tumor. Okay? So, these are the causes of intestinal obstruction. How do these usually manifest? So, dahil may bara ka, magkakaroon ng abdominal distension and pain, and then pwede kang mag-vomit, no? And as well as constipation. Okay, next. Yan, inflammatory bowel disease. Okay? So your IBD is a chronic inflammation that is usually due to inappropriate mucosal immune activation. Ibig sabihin, your immune response to the normal microbiota of the gut is OA. At dahil OA yung inflammation nila, doon nagkakaroon ng manifestation. Ang classic population na na-affect ay usually mga teenage or early 20s and more of female more than male. Okay, ang important lang malaman natin dito is how to distinguish these two, no? Which compromise your IBD. Crohn versus ulcerative colitis. Okay, so yun yung pinaka-important na matandaan nyo lang dito. At if meron kayong tatandaan, itong dalawang difference lang. Okay? Una, what segments are affected? And two, how deep. Okay? So, aling segments affected? So, ulcerative colitis, no, from the name colitis, it's the colon, rectum and colon. Okay? So, the rectum and the colon are the one affected and it's continuous. So, it's the colon, the rectum, and it's a continuous involvement segment. In contrast, your Crohn, it can affect any part of the GI tract or the intestines, no? Small intestines, sa colon, sa rectum. Pero, area siya, hindi siya continuous. That's why you have your skip lesions or lesions na normal. Okay? The most common location of your Crohn's is the ileum. No? Ileum. But again, it can occur at any part of the GI tract. And hence, it's also called regional enteritis. Okay, so, yun, segment affected. Second is the depth. Okay? Yung ulcerative colitis hanggang submucosa lang. So, mucosa and submucosa. Okay? In contrast, your Crohn is a transmural inflammation hanggang serosa niya. Okay? So, ito yon. The entire layer of the abdomen of the GI tract. Okay. So, yun yung two important difference nila. Okay. In addition to that, the ulcers of these two are also different. Your Crohn's disease tend to be more deep and knife-like, while your ulcerative colitis has superficial and broad-based. For Crohn's also, yung initial ulcer nila, usually tinatawag na aphthous ulcer. Okay? And then, ang Crohn, siya yung mas maraming mga characteristics. No? So when in doubt, Crohn yung merong ng ganito. Ito. So for example, sino yung usually may fibrosis or serositis or granuloma or fistula? Crohn. Okay? Crohn yun usually, as well as strictures. So usually nagpo-form sila ng strictures. So when in doubt, Crohn yun. Okay? Ang special lang sa ulcerative colitis is that you can have this toxic megacolon. Okay? And the toxic megacolon can cause thinning of the wall. No? And in addition to that, dahil hindi nga complete yung involvement sa ulcerative colitis, okay, hanggang mucosa, hanggang submucosa, meron kang formation nitong parang mga polyps na to. Pseudo-polyps. Okay. And that pseudo-polyps can have bridges between them. Okay? So, yun. Okay, by the way, so a hallmark of your Crohn's disease is granuloma, specifically non-caseating granuloma. So hallmark of Crohn's disease, non-caseating granuloma. But take note, hindi lahat ng Crohn merong ganun. Okay? Only around 35%. So the absence of a granuloma does not rule out Crohn. Okay? Also, ito pa meron sa Crohn. So sabi ko basta when in doubt, Crohn usually, no? It also pwede rin magkaroon ng mga malabsorption. No? Vitamin, fat malabsorption, iron deficiency. Bakit? Kasi your small intestines can be affected. Diba? And doon nangyayari yung mga absorption. So, pwede ka magkaroon ng malabsorption sa Crohn's disease. Okay. So, ano yung mga symptoms, no, of this inflammatory bowel disease? More or less similar lang naman sila. Usually sa chronic relapsing disease, no, meron kang times or episodes of abdominal pain, cramps, diarrhea, no, bloody diarrhea. And then in between them, you have episodes of walang symptoms. No? Mga weeks, months na walang symptoms, then may episodes ka na naman. And usually may triggers yan. No? Like stress. No? Now ito, ito rin yung difference sa Crohn and ulcerative colitis. No? Sa Crohn, smoking is a trigger. Okay? Smoking is a trigger. In fact, when you start smoking, yun usually yung initiating event on having Crohn's. Okay? Pero sa ulcerative colitis, smoking even partially relieves the symptoms. Okay? So very opposite yun. So Crohn, smoking is a trigger. Ulcerative colitis, smoking is a partial relief. Okay. Last na gusto kong sabihin dito sa dalawang to is that they have potential to develop malignancy. Okay. So sa Crohn, usually pag may colonic involvement, ulcerative colitis, laging colon naman yung involved, pwedeng magkaroon ka ng cancer, colon cancer. And this is usually associated with the duration. The longer na meron kang inflammatory bowel disease, mas malaki yung chance na mag-develop ng cancer. Usually mga 8 to 10 years. No? So kaya ang isang patient na may IBD, after 8 to 10 years, you check. No? Second, the involvement. No? So kung halimbawa yung buong colon involved, mas malaki ulit yung chance. And third, the severity. Pag sobrang lala yung symptoms at yung inflammation, mas malaki yung chance na magkaroon ng cancer. Okay, last disease we'll talk about for the GI is colon adenocarcinoma. Okay, so this is the most common malignancy of the GI tract. Usual risk factors, age, usually past 60 years old, and then diet, low fiber diet, high carbs, high fat. So ang pag-uusapan natin dito are the two general pathways in the pathogenesis of colon cancer. First is, and more common, which accounts for 80% of sporadic colon tumors, is your classic adenoma carcinoma sequence. Okay, so the classic adenoma carcinoma sequence tells us that there are accumulation of mutations along the way that leads to the development of a normal colon to an adenoma to the carcinoma, and that these mutations have a specific sequence, more or less. And one of the early mutations involved the APC gene. Okay? The APC gene was already mentioned on chapter 7. No? So let's recall a little bit. The APC is a tumor suppressor gene. What it does is that it binds with beta-catenin and degrades it. Kasi ano bang ginagawa ng beta-catenin? Beta-catenin binds with your transcription factors and causes production of growth factors for proliferation. So by degrading that, you have less proliferation. EPC then is a tumor suppressor gene. And it's one of the early mutations present in this sequence. No? Being a tumor suppressor gene, it follows a two-hit hypothesis. No? So kailangan meron kang dalawang mutations, no? Your both genes are inactivated. Both alleles are inactivated na APC. Okay. Then later on, what they noted was meron ka ng mga KRAS mutation and T53 mutation, which tend to be later mutations. Okay? Because sa mga adenomas, hindi siya ganun ka-common. Pero sa mga carcinomas, mas meron ng mga KRAS and T53 mutation. Okay, so yun na yung point din here. To note, your familial adenoma polyposis, or FAP, have an inherited mutation of this APC. Kaya mas mabilis sila mag-develop nitong cancer na ito. Okay, side note also, how do you diagnose FAP? You need to detect at least 100 polyps. Okay? And usually, or almost always, by age 50, pag wala kang ginawa sa isang patient na may FAP, magkaka-cancer na yan, colon adenocarcinoma. And then often 30 years old pa lang meron na sila. Pero 50, sure, meron na sila. Okay, so that's one molecular pathway for developing colon cancer. Another one is this microsatellite instability pathway. So what happens is you have DNA mismatch repair that is mutated. And this mutation causes the accumulation of your microsatellite repeats. Your microsatellite repeats. And hence you have microsatellite instability. Okay. Grossly, your MSI mutated na cancer tend to have sessile serrated na adenoma. Okay? And mucinous na adenocarcinoma. So yun yung usual characteristics. So kung FAP, usually APC, yung mutation, your Lynch syndrome, which is the most common na colonic syndrome, tend to have this mismatch repair na mutations. Okay, yun yung na-inherit. Okay, so yun, the two pathways that can lead to colon adenocarcinoma. Okay, now morphologically, grossly, colon cancer that are located at the proximal colon, sa mga ascending colon, tend to be polypoid and exophytic in nature. And since malaki yung caliber ng mga ascending colon, yung mga nasa proximal colon, hindi masyado common na merong obstruction to. Okay? So wala masyadong luminal obstruction kapag ang cancer nasa proximal colon. Sa distal colon, however, rather than exophytic masses, they tend to have annular lesions, aka a napkin ring constriction. So doon, pwede talaga magkaroon ng luminal narrowing. So correspondingly, ganun din yung manifestations. No? So right-sided colon cancer, hindi masyadong nagmamanifest yan with obstruction or constipation, etc. More of fatigue, weakness, and iron deficiency anemia. Okay? So pwedeng iron deficiency anemia lang ang manifestation ng colon cancer. So in an elderly man o postmenopausal woman who manifests still with iron deficiency anemia, you must consider GI cancer. Okay? And unless you rule that out, that's the main consideration. Left-sided colon cancer, on the other hand, tend to manifest with bleeding talaga. Or meron kang changes in bowel habit, constipation, because you have luminal obstruction, pain, and discomfort. Okay, so very similar to your gastric cancer, the most important prognostic factor for colon cancer is also the depth of invasion as well as lymph node metastasis. Also, if you have distant metastasis, the most common site of distant metastasis of colon cancer is your liver. Okay? Okay. So I'll be quick na lang on the last two chapters kasi overcome na ulit ako. So, okay, let's start. So liver and gallbladder. So to better understand the various insults to the liver, it is important to know the anatomic organization. And this is the lobule model of the liver. So, di ba, usually, your blood comes from your portal vein, 70%, 60 to 70, and your hepatic artery, around 30 to 40%. And then they will now enter the hepatocyte, traverse the sinusoid, blood traverses the sinusoids, then they will now drain to the hepatic vein. No? So the organization is that hexagonal, yung hepatocytes. No? And your hepatic artery and portal vein here are at the periphery. Okay? And your center is the hepatic vein. At tinatawag niyo siyang central vein. Okay. The hexagonal lobule can further be divided into acinine, no? Which is triangular. So 6 acinine. The one closest to the hepatic artery and portal vein is the zone 1. And then as you go closer to the central vein, zone 2, then zone 3 is the closest. So zone 1 is also known as your periportal. It's close to the portal vein. And then your zone 3 is also known as pericentral because it's close to the central vein, or centrilobular because it's near the center of the lobe. Okay? So anong clinical significance niyan? No? So if you have ischemic injury, for example, saan mas significant yung injury? Sa zone 3. No? Because if you have ischemic injury, malayo na yung zone 3 from the blood supply, which is your portal vein and hepatic artery. How about if you have acetaminophen toxicity, which is the most common cause of acute liver failure, especially in the Western world? No? So dahil okay, zone 3 pa rin. No? That is because your metabolic activity is also different across the zones. No? The zone 3, doon pinakamataas yung cytochrome activity. And important in the acetaminophen toxicity is the cytochrome activity. So kaya yung mga toxins na minametabolize by cytochrome na system, mas mataas yung toxicity niya sa zone 3. Paano naman yung mga direct toxic talaga sa liver? Zone 1. No? Zone 1 naman yon kasi sila yung diretsong sasalo sa blood supply. So sila yung unang-unang madadamay kapag meron kang direct toxic injury to the liver. So yun, that helps us understand bakit merong mga centrilobular na necrosis or periportal na necrosis in the liver. Depende sa insult. Okay. So for the liver, let's just focus on the fatty liver disease. No? And a major cause of fatty liver disease is alcohol. So kaya na-differentiate na siya. Alcoholic and non-alcoholic liver disease. So let's start with alcoholic first. What is significant alcohol intake? It's around 80 grams. 80 grams of alcohol is around 6 bottles of beer. Okay? So But the impact of alcohol also is affected by other factors. In fact, around 10 to 15% lang of heavy alcoholics really develop severe disease, severe liver disease such as cirrhosis. No? So what are these factors? Women are tend to be more susceptible. No? At the same dose for those with men, mas malaki yung liver disease sa women. There are genetic factors, no? Such as your aldehyde dehydrogenase. No? So kung pag mababa yung aldehyde dehydrogenase activity, there is higher liver damage. No? Pinaka-example niyan sa Asians. No? Around 50% have low activity of aldehyde dehydrogenase. Kaya meron kang tinatawag nating Asian flush. Diba? And other comorbid conditions. For example, meron na siyang hepatitis, tas lasengo pa siya, no? Mas malaki ang chance na magkaroon siya ng alcoholic liver disease. Okay, there are three distinct forms, no? But can be overlapping forms of alcoholic liver disease. No? Hepatic steatosis, alcoholic hepatitis, and fibrosis. Okay, so what happens here? So for example, you drink nung last weekend, no? 80 grams of alcohol, 6 bottles of beer. If you do that for just a day, several days, the next mornings, meron ka na nitong hepatic steatosis, which is just fatty change. Okay? And that is very much reversible. Pag hindi ka uminom ulit for a few months, babalik na naman to the normal level. Okay? Now, if inom ka ng inom daily for years, no, and we're talking about 10, 20 years here, that cumulative damage ultimately results to fibrosis, which is a response of the liver to that injury that becomes maladaptive in the long run. So fibrosis. Pag uminom ka naman ng sobrang lala, high amount of alcohol that immediately causes inflammation, some areas of necrosis, na that is your alcoholic hepatitis. A very severe exposure. Pwede yan mangyari sa isang may normal na liver or isang lasengo na may fatty change na talaga. No? If that damage, no, we have repeated attacks, paulit-ulit kang may mga ganon of high amounts of alcohol. Again, no, cumulative damage over time. No? The liver responds to it and becomes maladaptive. That will also ultimately lead to fibrosis. Okay? So, yun yung spectrum na to. Let's look at morphologic features. No? So, when you say steatosis, again, that's fatty change. And findings there would be, you have lipid droplets. Okay? Pwedeng maliliit muna na lipid droplets, then they can coalesce to form bigger lipid droplets. And they can be of macrovesicular or microvesicular form. Microvesicular is also known as alcoholic foamy degeneration. Among the two, mas common na macrovesicular form. Okay, so let's just look at this image. Ito yung mga lipid droplets. No? Lipid droplets. Sorry. Okay. So, alcoholic hepatitis naman, necessary to diagnose your alcoholic hepatitis is what you call ballooned hepatocytes. So what are ballooned hepatocytes? These are swollen hepatocytes because of damage and nag-clear out yung cytoplasm. You also have cytoskeletal damage. Here, the image below shows hepatic alcoholic hepatitis. No? So ito, look at the hepatocytes. They are enlarged, no? Very swollen. And then, yung cytoplasm nila cleared out. Okay. In very severe cases, no, extensive yung damage, meron kang mga proteins na hindi na-degrade. Partially degraded lang na proteins. This is what you call your Mallory hyalin. Ito yan. Also a sign of hepatic alcoholic hepatitis. Okay? Necessary to diagnose is only the ballooned hepatocytes. Okay? Since hepatitis, meron ka rin inflammation, minsan may mga neutrophils, but minsan may areas of necrosis, but not that extensive actually. Again, still reversible. Now, ultimately, as a response again to injury, magkakaroon ng fibrosis. No? Initially, very sinusoidal, no? Or pericellular yung fibrosis. Here, this yung mga blue na stain here, no? Between the cells, between sinusoids, that's your pericellular fibrosis, which has a also known as a chicken wire appearance. Okay? And then grossly, ito, you have your nodules. More commonly, micronodular, mga less than 3 millimeters lang yan. Okay? So those are the different forms of alcoholic liver disease. Okay. Pwede rin, mayroon kang fatty liver disease na non-alcoholic. Very similar actually yung morphology. Ang kaibahan lang, hindi siya umiinom or yung level na iniinom niya, hindi yung 80 grams na pinag-usapan natin. Okay? Usually associated to with metabolic syndrome. Obesity, DM, hyperlipidemia. No? But again, very similar lang yung mga findings. So meron kang steatosis, may inflammation, and again, balloon hepatocytes. Okay, so yun lang muna for the liver. Okay? Now, let's go quickly to the gallbladder. So inflammation of the gallbladder, cholecystitis. So let's just compare acute and chronic cholecystitis. So majority of acute cholecystitis is due to gallstone that obstructs either the neck or the cystic duct. Okay? And that's what you call calculus, no? Acute calculus cholecystitis. But in 10% of cases, walang stone. And that can be due to ischemia. Now, remember that your cystic artery is an end circulation. Wala kang collateral stone. So kapag meron kang damage sa cystic artery or meron kang ischemia at that area, wala, no? So usual causes nito, meron kang mga sepsis, mga hypotensive, or major trauma, or burn. Okay? But again, majority is calculus naman. Yung findings nila, the usual lang na acute inflammation. Meron kang mga edema, hyperemia, no? Paminsan you also have neutrophilic infiltrates. Okay? Now, complications of this acute cholecystitis, no? Pwedeng kapag purely pus na talaga yung nag-accumulate, no? Pwede kang mag-empyema. Especially, pwede ka kasing magkaroon ng superimposed na bacterial infection later on. And then if malalang-malala yung inflammation na meron ka ng necrosis, na green or black na itsura ng gallbladder, tapos may perforation, no? Gangrenous cholecystitis. And another complication, especially if meron kang superimposed na mga clostridial organisms, no? Emphysematous, meron kang air within the wall. Sa chronic cholecystitis, usually, kapag may repeated bouts ka of acute cholecystitis, they can culminate to chronic cholecystitis. In 90% of cases, it's also associated with gallstones. No? But hindi necessary na may obstruction. Okay? The relation of the gallstones to the pathogenesis of cholecystitis is not actually clear. No? More likely na pareho lang sila associated with the supersaturation of the bile. No? So pag supersaturated yung bile, magpo-form ka ng stone, at the same time, magkakaroon ka ng chronic cholecystitis. And since chronic, no, parang the usual chronic inflammation lang, meron kang fibrosis. No? And perhaps a unique finding is this Rokitansky-Ashkoff sinuses, which are outpouching of the mucosa wall. Okay, so last topic, no? Pancreas. Short lang to. So let's just discuss pancreatitis and pancreatic cancer. So pancreatitis, no, acute versus chronic. So acute pancreatitis, it's a reversible parenchymal injury and inflammation. Okay? So the most common cause is actually gallstones, no, that causes pancreatic duct obstruction and alcohol. So these two causes account for more than 80% of acute pancreatitis. No? But you can also have other causes like hyperlipidemia, vascular infections, no? Like mga ascariasis, no? Pwede rin mag-cause ng acute pancreatitis. ERCP procedure can also cause that. No? Again, majority are caused by gallstones and alcoholism. Ano bang nangyayari sa acute pancreatitis? No? You have inappropriate activation of your pancreatic enzymes na nasa pancreas pa lang. And that causes autodigestion and parenchymal damage. Okay? So bakit nagkakaroon ng ganun? For example, sa gallstones, it causes pancreatic duct obstruction. So nasa-stuck yung enzymes doon, activate sila, magkakause ka ng autodigestion. Alcoholism also can cause activation of your enzymes by two mechanisms. Obstruction because alcohol can cause contraction of your sphincter of Oddi, and at the same time, it can cause acinar cell injury. If you damage your acinar cell, pwedeng ma-release yung enzymes. No? So inappropriate release and activation of your pancreatic enzymes, yung pathogenesis nito. Okay, so morphology. Being an acute inflammation, the usual lang na acute inflammatory changes. No? So meron kang microvascular leak and edema, acute inflammatory changes, minsan may mga neutrophils ka. As I mentioned, you have parenchymal damage due to autodigestion. No? Siguro what is unique is your fat necrosis, which was all mentioned in chapter 2, di ba? What happens is because your lipases are released, no, it causes degradation of your fat. No? And the fatty acid will now form, along with your calcium soap, no? And cause saponification. Okay? Na pag sobrang malala yung acute pancreatitis, pwede siyang mag-cause ng blood vessel destruction and a hemorrhagic type of pancreatitis, which is really bad. No? So ano bang usual presentation nito? Diba? Acute onset na gastric pain, na boring. No? In severe cases, pwedeng pa-sepsis, pa-shock. No? Ganun, no? Acute pancreatitis. So this image shows the fatty necrosis in acute pancreatitis. Okay, let's contrast that to chronic pancreatitis. Chronic naman is a more prolonged inflammation and irreversible. Okay? And it's characterized by these. No? You have loss of exocrine pancreas, parenchyma, as well as endocrine later on. No? And of course, characteristic of any chronic inflammation, fibrosis. No? Lagi yan, pag chronic inflammation, fibrosis. The most common cause is long-term alcohol use. Okay? So pag acute, mas common, ang pinaka-common, gallstones. Chronic, pinaka-common, alcohol use. Okay? What happens here? No? Usually, meron kang repetitive attacks of acute pancreatitis that ultimately leads to this chronic inflammation. Okay, so morphology-wise, no? The usual na chronic inflammation, meron kang fibrosis, no? And you have parenchymal loss, no? Acinar atrophy and dropout. So yung manifestations niya ay due to the loss of the cells, na functional manifestations. So for example, dahil nawalan ka ng exocrine pancreas, parenchyma, magkakaroon ka ng mga pancreatic insufficiency, malabsorption, no? Because you do not produce these enzymes. And dahil meron kang later on, loss of endocrine na rin, yan, magkakaparang DM ka. Okay? There can also be variable ductal dilation. Okay? So, that's acute versus chronic pancreatitis. Anong usual presentation ng chronic pancreatitis? Maraming episodes ng acute pancreatitis, no? As well as yung mga sinabi kong malabsorption and DM. Okay, so that's it na for pancreatitis. Very briefly, daanan lang natin ang pancreatic cancer because it's actually one of the more lethal na cancer. No? And the major reason for that is when it presents, it's too late. No? Pag may symptoms na, halos wala, masyadong mababa na yung cure rate. Okay. Pathogenesis-wise, an important mutation present is your KRAS, which occurs in more than 90% of patients with pancreatic cancer. Familiar, KRAS? No? We've also mentioned it in your colon cancer, di ba? One of the late mutations of colon cancer. Very important to note here, the strongest environmental influence in pancreatic cancer is cigarette smoking. Okay? Now, the cancer can occur at any parts of the pancreas. No? The most common is sa head. Okay? Now, pag nasa head siya, mas nagiging symptomatic siya, specifically with obstructive jaundice, di ba? Because the head of the pancreas, nandun siya sa may duodenum, and then it can also impede your common bile duct. So kapag nandun yung tumor, magkakaroon ka ng blocks sa common bile duct and can lead to obstructive jaundice. And a clinical sign, no, it gives you a clue to pancreatic cancer, cancer in general, is your Courvoisier gallbladder, which is a palpable, non-tender gallbladder. Pag meron kang nakita na ganun sa PE, mag-isip ka na ng cancer. It's probably a cancer. Anong usual presentation nito? Anong classic na tinuturo sa atin, di ba? Painless jaundice. Okay? Usually kapag nasa head. Ngayon, pag nasa body or tail yan, okay, medyo problema. Because wala siyang ma-obstruct doon. At doon, magiging mas malala because it is clinical inapparent until very, very late, very advanced. Okay? So, there are two characteristic features of your pancreatic cancer morphologically. Una, it's very, very invasive. Okay? It extends to those surrounding tissues. And second, it has a very intense desmoplastic response. Okay? So, kung mag-isip pag pancreatic cancer, just think na very malala. Very malala. An important marker we should remember is your CA19-9. No? It is used to monitor response to therapy. Okay, so basically yun lang naman for pancreatic cancer. Okay, so more or less, I think we've covered the more important diseases in these 4 chapters. Nakaka-overwhelm, no? Ang dami-daming kailangan aralin. But don't be too pressured. Huwag masyado ma-overwhelm. Try to learn as much as you can and be kind to yourself. No? Kung sa unang basa, normal talaga na hindi mo matandaan. It's normal to forget these things. You just keep on repeating and repeating them. No? Forgetting actually is part of the remembering process. Okay? And just enjoy learning, especially during your rotation. So have a great day to all of you.